Good morning and welcome to today's clinical meeting. For the first presentation, we have Dr. Abisha from Medicine 1. Always be careful.
Good morning, everyone. Today I'll be presenting on On examination. He was conscious, oriented, not in any distress. He was vitally stable, and on general examination, there was only icterus. Systemic examination had revealed a palpable liver of 3 cm and a liver span of about 20 cm with no other significant findings. So I'm summarizing, this is an elderly microbiologist who was a chronic hepatitis B carrier who spontaneously cleared the virus in 2011, had presented to us with excessive fatigability, loss of appetite, and on examination had icterus and hepatomegaly. Can someone, the differentials? So it's taking longer, we'll just proceed with the presentation. So the differentials we considered in this patient was, since he came with the acute history, our first differential was hepatitis, which was either an acute hepatitis or a chronic hepatitis or a hepatocellular carcinoma, because he had an enlarged liver, a metastasis from an unknown primary, or lymphomas or leukemias. These were our top differentials. With this in mind, we did the initial investigations, which showed a hemoglobin of 11.9, a total count of 12,500 with 75% neutrophils. Platelets were 3,83,000. There was hyponatremia, hypokalemia, and bicarb was 15. However, normal creatinuria were there. LFT at presentation had shown direct hyperbilirubinemia, cholestatic picture with a low albumin, 2.7, elevated liver enzymes, and alkaline phosphatase was also 384. Just would want to highlight his previous investigation, just to note that in 2010 and 2021, in between there were multiple LFTs. Just wanted to highlight that all his LFTs were within the normal ranges with normal SGOT and PT. This was at presentation to us in 2023, where he had a direct hyperbilirubinemia with hypoalbuminemia and transaminitis as well. His progressive LFTs during a hospital stay had shown a significant worsening from 2. Within a month, it had gone up to 14, and the enzymes were also showing a significant elevation. So why this cholestasis? The etiological workup with ultrasound abdomen on 24th had revealed multiple hyperechoic lesions in the liver, the largest measuring 10 cross 10 centimeter. Keep in mind that this was done on 24th. And alpha fetoprotein levels were 29,813. So our diagnosis was hepatocellular carcinoma was very evident. And CT abdomen we did in 28-4, which had shown multiple hypodense lesion, and the size within 4 days had become 14 cross 8 centimeter. It was rapidly growing mass, and this was consistent with hepatocellular carcinoma with a Lyrod staging of 5. So a complete diagnosis was hepatocellular carcinoma after HbSAg seroclearance in a patient who was a diabetic hypertensive, had chronic venous stasis with stasis eczema and trigeminal neuralgia. So in my presentation, I would want to highlight only 4 things. Why did hepatocellular carcinoma occur in this patient even after HbSAg was cleared? And how do we diagnose hepatocellular carcinoma without any biopsy? And how to follow up any patient with chronic hepatitis B? And how to decide on plan for further management? So why did this patient have HCC? So as we all know, hepatitis B virus is a DNA virus. It integrates with the host chromosome. As it integrates, it increases the instability of the host genome and also creates epigenetic remodeling of the host DNA. All of these lead to abnormal expression of oncogenes and tumor suppressor genes, thereby inducing mutations within the host gene. So that is why even after the virus is cleared from the serum, the host gene is mutated that can progress to develop a carcinoma. And in their studies 108.9 months. There was another study which was published in 2000 at a median of 56 months to a maximum of 2 HbSAg seroclearance, patients can develop a hepatocellular. So what are the risk factors? Any patient with a pre-existing liver disease has developed a chronic hepatitis B, HCC. The risk factors include alcohol use, male sex, older age, presence of HBe antigen, elevated HBV DNA, and co-infection with hepatitis C. These parameters are present in our patient during follow-up, then that means the patient can anytime progress to HCC. HBV DNA more than 2000 is at increased risk. However, one thing to notice, even if patient has less than 100 international units with low level of viremia, they are also at increased risk of HCC. It doesn't mean that we can't follow up the patient. It doesn't mean that if patient is zero cleared, we should not follow up the patient. We have to keep this patients under follow-up. And the HbSAg levels of more than 100, especially more than 1000, poses an increased risk. And the other factors include elevated ALT levels, and increased fibrosis score, all are at increased risk of developing a hepatocellular carcinoma. I would also want to highlight on how to follow patients with chronic hepatitis B. There are two things that we have to see. One is HBs antigen, another thing is HBe antigen. If both are positive, we look at alanine transaminase levels. If it is more than twice the upper limit and HBV DNA is more than 20,000, that is an indication to treat the patient with antiviral. If ALT is less than upper limit of normal with elevated HBV DNA, we do not treat the patient. We monitor the patient with ALT, AST every 6 months with HBe antigen annually. And we follow the serial thing and decide on treating the patient. The intermediate category, where it is less than twice the upper limit of normal, and the HBV DNA is somewhere between 2 to 20,000 or even more than 20,000, we have to exclude other causes of alanine transaminase elevation. We can also decide on whether to biopsy the lesion or not. And then if all the other causes of are excluded and the patient is more than 40 years of age, then it is an indication to treat. The other scenario is when HBsAg is positive, but E antigen is negative. In this condition also, if alanine ALT is more than twice the upper limit of normal and HBV DNA is more than 2,000, here it is 2,000, that it was 20,000, it is an indication to treat. If it is less than upper limit of normal and less than 2,000, then do not treat, monitor. Anywhere in between, we just exclude the other causes of ALT elevation and then decide on treating the patient. So after seroclearance, what to do? This is mentioned in the guidelines because it is so frequent that patients even after seroclearance can develop HCC. We have to screen patients after seroclearance with AFP and ultrasonography every 6 months or sometimes annually. In our scenario, this is a US based guidelines. So at least in our scenario, we have to do once in a year, and they have mentioned that AFP and ultrasound together have increased sensitivity specificity when compared to a single testing. And how do we diagnose? I would just want to highlight in my patient, because the lesion was more than 14 centimeter with elevated AFP levels with the LIRAD staging of 5, which is consistent with hepatocellular carcinoma. We didn't biopsy, we just started treating the patient. This is one of the very few malignancies where we do not need a biopsy evidence to treat a patient. And if it is less than if the nodule is less than 1 centimeter, follow up with ultrasound. If it is more than 1 centimeter, go for a CT or an MRA and then decide on biopsy based on the LIRAD staging. This is the LIRAD staging where LIRAD's 5 is definite of HCC. Anything before this, consider biopsy. Anything above this, no need for a biopsy, you can actually start treating the patient. And the same thing, if it is LIRAD's 5, you do not need a histological confirmation. And how to manage? So in our patient, the patient had actually discharged and came back within a week with ascites, progressive breathing difficulty. And as I had already shown, the bilirubin was serially elevated and patient was in liver failure. So he came into this terminal stage, though at presentation he was at this intermediate stage. So intermediate stage, the treatment is chemoembolization and the survival is expected to be more than 2.5 years. But when the patient comes with terminal stage, the survival is only 3 months, and what we can offer is best supportive care. The other stages, there are resection, ablation, chemoembolization therapies, or systemic therapies with chemotherapy is also available with sorafenib and all. So in our patient, we obtained MDT discussion was made. Hepatobiliary was involved. They told because of extensive disease, no intervention was planned. My donc also told he was not a candidate for systemic therapy. So palliative therapy was given, and finally we provided the best supportive care. But the patient passed away within three weeks of diagnosis of the hepatocellular carcinoma. So it was a rapidly growing mass with rapid decompensation. That's why we couldn't do anything but to support the family. Thank you.
Any questions?
Sure. So was this patient tested for hepatitis B?
No, sir.
Possible he could have had a
co-infection also.
Hepatitis B cleared out, but he is
was not tested.
Could test that.
Did this patient have an ultrasound in 2021?
It was all normal, ma'am.
Ultrasound was also there.
Normal. In 2015 was the last ultrasound, but it was normal. After that, in presentation only we did.
So now, how do you think we can follow up our treated Hep Bs?
One is LFT monitoring. like at least enzyme monitoring to be cost effective once in 6 months at least, and HBE antigen to be repeated annually, and ultrasound at least annually for our patients.
There are actually score calculators to see who are the patients who will actually progress to HCC. You know some scores? There are scores, reach, B, page, some other 2-3 scores are there. So you look at the scores, those who are risking high on those scores need to be having a closer follow-up. Sure. Next. Thank
Could
you.
I make a point?
So next we'll have Dr. Aishwarya from Medicine 2.